Please, Dr. Saiful Islam, come on dais and give your deliberation.
Today's honorable chairpersons, my respected teachers and learned audience, I would like to begin thanking you all for coming here today. And it's a very good morning and assalamu alaikum. I am Dr. Saiful Islam Moon, Specialist Nephrology, BRB Hospital Limited. It's my great pleasure to be here today, and let's go start. Today my topic is steroid in drug-induced AKI. I will speak logically for it. Something about introduction. Drug-induced acute kidney injury is relatively common, affecting about 13% to 20% of patients with unexplained AKI in clinical practice and leads to CKD and end-stage renal disease. Drug-induced acute interstitial nephritis accounts for 70% of these. Following drug-induced AKI, 40% will be left with CKD and 10% will progress to end-stage renal disease. The role of steroid treatment in drug-induced AKI is controversial. We know that most common causes, but most important are drug-induced acute interstitial nephritis are antibiotics, NSAIDs and PPIs. Now in short, mechanism of drug-induced AKI, direct acute tubular injury, induction of localized inflammation and intratubular obstruction. Now the pathogenesis of drug-induced AKI, this is the most important here. The medications or their metabolites elicit type B idiosyncratic cell-mediated immunological response through bind to tubular basement membrane, and this causes antigen presentation to helper T cell, and then subset of helper T cell produced, and they also produce various of cytokines such as interleukins and interferons. And finally, they attract number of cells like macrophage, eosinophils, CD8 T cells and mast cells and basophils. Finally, acute interstitial nephritis. Now, what are the histological findings we found here? Just the initially interstitial edema, cellular infiltrate with predominance of CD4 T lymphocytes, plasma cells and eosinophils, tubulointerstitial inflammation, fibroblast stimulation and epithelial mesenchymal transformation, interstitial collagen deposition, irreversible tubular atrophy and tubular interstitial fibrosis, and finally CKD. Now, are corticosteroid effective for treatment of drug-induced AKI? Yes. Glucocorticoid can prevent activation of inflammatory pathways. Glucocorticoid binds to their respective cytoplasmic glucocorticoid receptor, and this complex binds to the glucocorticoid response element within the T lymphocyte DNA, and that causes upregulation of messenger RNA transcription and translation of anti-inflammatory proteins. The most important another one, inhibition the K pro-inflammatory transcription factor KB element, which is a pivotal role in promoting renal inflammation in various disease. This is an original article thus published in Kidney International Journal. Early steroid treatment improves the recovery of renal function in patients with drug-induced acute interstitial nephritis. Here they concluded that therefore our study strongly suggests that steroid treatment is indicated in drug-induced acute interstitial nephritis, and that it should be started immediately or soon after the diagnosis to avoid the risk of incomplete renal function recovery. No significant side effect attributed to steroid were observed, probably due to the short duration of the treatment, that's the 8 to 12 weeks. This scatter diagram showing there is significant correlation between the delay in the onset of steroid treatment after drug withdrawal and the final serum creatinine. Here the early steroid started, there is creatinine level decreasing early, and the delay the creatinine level decreasing baseline to normal delays. This another comparison showing, this scattergram showing that the rate of renal function recovery expressed by a 50% decrease in highest serum creatinine in group 1A, and a complete recovery of renal function, and group 1B incomplete recovery. This is the clinical journal American Society of Nephrology published 2018, duration of treatment with corticosteroids and recovery of kidney function in acute interstitial nephritis. Here they concluded high dose corticosteroid treatment for 3 weeks or prolonged treatment for more than 8 weeks were not associated with greater kidney function recovery in drug induced acute interstitial nephritis, but a delay in the initiation of corticosteroid resulted in worse recovery of kidney function. This another journal is length of corticosteroid treatment associated with recovery of kidney function in drug induced AIN. Here 182 cases of biopsy proven drug induced acute interstitial nephritis patients were taken. Here the findings were NSAIDs identified as a culprit 27%, and the median time of drug withdrawal 11 days, and median initial dose was 0.8 milligram per kg. Here we found that recovery 41% and 46% partial recovery and 13% no recovery. It's a large study for multiple. Here shows that corticosteroid is effective in drug induced acute kidney injury. Now we go through a problem based learning. Patient 1. A 25 years old woman with acute pyelonephritis from Escherichia coli was treated with oral double strength sulfamethoxam and trimethoprim on day 11 of 14. The patient developed a maculopapular rash, low grade fever and eosinophilia. Serum creatinine was 1.9 milligram per dl, thus baseline was 0.7 milligram. Urine sediment microscopy revealed 1 to 3 WBC cast per low power field. AIN due to sulfamethoxazole was presumed and drug was discontinued. Treatment was completed with 3 days of daily levofloxacin. Over the next weeks, her symptoms resolved and serum creatinine returned to baseline. Another one, 69 years old man with coronary artery disease, atrial fibrillation and hypertension was admitted to the ICU for pneumonia complicated by hypotension. After clinical improvement with ceftriaxone and azithromycin therapy, he was transferred to a medical floor. On day 9, the nephrology service was consulted to evaluate his serum creatinine rise from 1.2 to 2.1 milligram per dl. Urine sediment microscopy demonstrate 5 to 10 isomorphic RBC per high power field, 10 to 15 WBCs per high power field, 3 to 5 epithelial cells per high power field, and 1 to 3 granular cast in low power field. ATN, acute infectious GN, and drug-induced AIN were considered in the differential diagnosis. And antibiotics were discontinued for clinical suspicion of drug-induced AIN. However, because the serum creatinine continued to rise to 5.7 milligram per dl on day 13, kidney biopsy was performed. Light microscopy revealed diffuse AIN, acute tubular injury, and 30% of immunointerstitial fibrosis. Ceftriaxone was the most likely culprit. IV methylprednisolone 500 milligram daily for 3 days was initiated, followed by oral prednisolone 60 milligram daily for 4 weeks with subsequent taper. 2 weeks after starting therapy, a gradual decrease in serum creatinine was observed. At 6-month follow-up, the patient's serum creatinine was 1.9 milligram per dl. Now learning. The first patient developed classic allergic drug-induced interstitial nephritis with systemic and kidney manifestations, whereas the second patient had only kidney manifestations that did not allow drug-induced AIN to be easily differentiated from other causes of AKI. Furthermore, the first patient had resolution of drug-induced AIN solely with drug discontinuation, whereas the second patient had worsening AKI, presumably from ongoing tube interstitial inflammation and injury despite drug discontinuation. Due to worsening to AKI, corticosteroid therapy was initiated and kidney function eventually improved over the next several weeks. Now, is kidney biopsy required to document drug-induced AKI before corticosteroid therapy? Clinical diagnosis of drug-induced AKI is challenging without a kidney biopsy. Early initiation of corticosteroid is associated with better long-term kidney function. Thus, a biopsy should be performed as soon as possible in those suspected to have drug-induced AIN or those with unexplained AKI to establish or rule out drug-induced AKI diagnosis. In patient where a biopsy cannot be performed and drug-induced AKI is the top diagnosis, a trial of empirical corticosteroid therapy may be considered on a patient-by-patient basis. Unfortunately, there is currently no invasive test that reliably diagnoses drug-induced AIN. Next, another, can early steroid treatment changes the natural course of drug-induced AKI? Or what is the optimal timing of steroid therapy in patient? Though the role of steroid for drug-induced AKI has caused controversy, two studies reported lower rate of kidney function recovery in those with a longer time from onset of drug-induced AIN to starting steroid. Most authors have recommended it should be initiated only with no evidence of renal function recovery after a 7 to 15 days observation period since suspension of the involved drug. Who should get steroid and how do we identify this group? Murithi et al. 2014 found that in increased amount of interstitial fibrosis or tubular atrophy and smaller kidneys on ultrasound correlate with poor response to steroid. Thus, corticosteroid should be avoided in those with advanced fibrosis, particularly in diabetes with labile blood glucose control and in patients with active infection. Unfortunately, there are currently no tests that can be recommended to replace biopsy to establish drug-induced AIN diagnosis. This is the algorithm for management of drug-induced acute interstitial nephritis. Here, possible drug-induced AIN, identify and withdraw the offending agent at first. Supportive care and monitoring kidney function over next 3 to 5 days. If kidney function improving, continue monitoring. Kidney function not improving or worsening, then go for kidney biopsy for other diagnosis. If kidney biopsy found AIN with more than 75% interstitial fibrosis, only conservative management, no steroid. If AIN with equal or less than 75% interstitial fibrosis, if there is no contraindication, start steroid. And if contraindication, other agent, I will say later. In patient where kidney biopsy cannot be performed, the decision to start a trial of empirical steroids can be considered on a patient-by-patient basis. And ultrasound showing small kidney usually indicate advanced fibrosis and unlikely benefit from corticosteroid. Now, what regimen and for what duration should corticosteroid be administered for drug-induced AIN? Drug-induced AIN studies have used either 250 to 500 milligram IV methylprednisolone followed by 1 milligram per kg per day of oral prednisolone or 1 milligram per kg per day of oral prednisolone without intravenous therapy. Prednisolone should be continued for approximately 1 to 1.5 months because most patients recover their kidney function within this time frame. A trial of corticosteroid should not be extended beyond 1.5 months in those who fail to show any improvement in kidney function. In patients with improving kidney function who developed adverse effect from corticosteroid therapy, a small case series support switching to mycophenolate mofetil as a potentially useful alternate therapy. Now, I am the ending of my presentation. Take home message. The pathogenesis of drug-induced AKI is postulated to involve cell-mediated immunity. As immune-mediated damage is hypothesized, therapy aimed at suppressing the immune response has been the mainstay of treatment for drug-induced AKI for over 4 decades. Management of drug-induced AKI primarily involved discontinuation of the offending agent and administration of oral or intravenous corticosteroid therapy, though results from various studies are conflicting. However, majority of reviews continue to advocate the use of corticosteroid therapy. Thank you for patient hearing.
Thank you, Dr. Saiful Islam, for your excellent talk.